Hey guys, we are live. Welcome to Ignite Nutrition's interview with Renae Hunter, Pelvic Health Physiotherapist from Evidence Sport and Spine here in Calgary. So I'm really excited to have Renae. We came into contact because her clinic is actually in my community down here in Mahogany. And I was looking for more information on where I could refer my IBS clients who are struggling or who I believe to be struggling with pelvic health. So Renae, thank you so much for coming today. I'm super excited to have you. Renae and I sat down for
Happy to be here.
we sat down for a coffee a couple weeks ago, and it was really nice to sit down and actually learn a little bit about how the pelvic floor plays a role in IBS and functional gut disorders. And so I wanted to bring Renae on to share her expertise with you on if pelvic floor could be contributing to your IBS symptoms, as well as some other symptoms that might come up that may trigger a need for a pelvic health assessment by a trained physiotherapist. So,
Sure.
Yeah, why don't you tell us a little bit about you, Renae?
Okay, so I've been working as a physiotherapist since 2009, mostly in the orthopedic practice, so private practice. And then I started getting interested in pelvic health just because I was seeing patients with sort of pelvic concerns that I was working externally, but sometimes the pieces of the puzzle weren't fitting together. And so I would end up referring to pelvic health therapists to look sort of more internal. And so I thought, why would I refer out when I can do it myself? So I started the training in 2015. And then I was on maternity leave, and I'm just come back this summer at Evidence Sport and Spine. So that's sort of where I've come today.
Awesome.
Mm-hmm.
And you're exclusively working in pelvic health now, right?
Yes, I still will see some of my previous clients in sort of an MSK. So if someone has a neck issue or pelvis, but yeah, trying to streamline my practice to predominantly pelvic health.
Awesome.
Yeah.
So why don't you go in ahead and tell us what exactly the pelvic floor is and what it does?
Okay, so the pelvic floor is a group of muscles that work together. So they're muscles that attach sort of from the front and sides of the pelvic bone and then into the tailbone in the back. So they act like a hammock or sling, giving support to our organs, so our pelvic organs, so bladder, uterus, prostate, rectum. So yes, they need to be working as a unit to function properly. So they have a few different roles. So a lot of people who've heard of the pelvic floor think of the sphincter action, so preventing leakage, both urinary and fecal, and then supporting the organs as well. But it also gives stability for our back and pelvis. So that works with our core muscles, which some people hear that term. It also plays a role in sexual function, and it assists our lymphatic system. So draining fluid from helping the veins to basically bring the blood back from the lower body into the trunk. So
Awesome.
A few different functions of the body, very important.
Yeah, I never thought of it as like a hammock before, kind of like holding everything in place, and it must carry a lot of weight and have to do a lot in terms of coordination.
Yes, yeah, and especially, I mean, we see a lot of women, generally a population that comes in are post-pregnancy, because that extra weight on the pelvic floor, people talk about it a little bit more. So that's where a lot of people start coming in, but there's so many people that are affected by this, and it's not just that pregnant population or postpartum population that are dealing with these issues. So
right.
Yeah.
I mean, that's important to know, because so many people do think it's, just something that they have to think about after pregnancy, but so many other people can be affected by it.
Mm.
And so why don't you go ahead and tell us why the pelvic floor is so important for bowel movements, because this is where my IBS clients sometimes struggle, in that maybe we've optimized all of their nutrition, but there still seems to be a component in which perhaps the pelvic floor is playing a role.
Yeah, so the muscles of our pelvic floor help control the act of defecation. So a successful bowel movement requires the coordination of both our abdominal muscles and our pelvic floor. So our abdominal muscles contract, and the pelvic floor has to relax to allow that proper evacuation. So there's a muscle in the back that acts like a sling, similar. And so when it relaxes, it opens it increases the angle to open the passage of your stool to pass through. And then you have your sphincter, more superficial, that a person would consciously decide when to relax and have the bowel movement. So both those muscles have to relax in order for us to defecate. So if we're having some coordination issues, then we can run into problems.
And I think a lot of times people think like, you know, pelvic muscles, I have to strengthen them, they have to be stronger. But I think people are often really surprised to hear that it's actually the relaxation of those muscles. And then of course the coordination piece as well.
Yeah, so I mean, the pelvic floor can have problems in a few different ways. So our two presentations that we commonly see is a lengthened and weak pelvic floor. So we'll see that with some stress and urge incontinence. So people who leak a little bit when they cough, sneeze, exercise, and with pelvic organ prolapse. But then we also see a lot of patients with a shortened and tight pelvic floor. So it's weak, but it's because it's short. So I always sort of tell people or give the analogy of if you were doing a bicep curl and you shorten the muscle and you're starting from here, if you were to try and contract that, you can't generate a lot of force. Whereas if you get those muscles lengthened and then you go to pick something up, you have a lot more strength. So we see sort of both. So sometimes the muscles are tight, sometimes they're they are lengthened and weak, or you can have a combination. So sometimes we'll see the right side is shortened and the left side is, or front to back. And then you can have that dyssynergy where I was talking about the coordination isn't working right. So we see it a lot with people with constipation, that they get into a habit of sort of chronic straining. And so when they're contracting their abdominal muscles, they're also contracting their pelvic floor. So tightening it, and you're trying to move the stool through a really tight muscular wall. So you'll get results of passing only a small amount of stool, and people will say that they feel they're not getting complete evacuation of their stool, and any sort of residual stool that's left there can slowly leak out and lead to that bowel incontinence piece.
Yeah, for sure. It's interesting to see that people can have, you know, different presentations of something where it might be the same thing going on. And then that mix between that constipation as well as that stool leakage, that people can see that combination with.
Yeah.
And so who is most at risk of pelvic floor dysfunction? Because I think people will be really surprised to find that it's not just that post-pregnancy population.
Yeah, so unfortunately being female is a big one. So we see it in female post-menopause, mostly from hormone changes and tissue changes. 1 in 3 women over 40 are incontinent. So it is very common. And it's not just people who've had kids. This is like the whole population. Pregnancy and childbirth do put you at more risk, so that's a risk factor. Having more than one child, any sort of trauma to any sort of obstetric trauma, so forceps, episiotomies, any tearing that's happened through delivery, but also any surgery, any sort of gynecological surgery or urinary surgery. Some people even after hernia repair, so an abdominal surgery where they cut through your connective tissue, that plays a role in our pelvic floor as well. And then just any chronic straining, chronic constipation, chronic bowel issues, that's a lot of pressure going through the pelvic floor. And if you develop poor habits, then it can lead to that sort of pelvic floor dysfunction as well.
For sure. So people that haven't had normal bowel movements in a very long time, and I don't know if you know this, Renae, but a lot of people waiting or struggling with IBS, average length to diagnosis is about 6 years. So people can struggle with bowel issues for 6 years before they even get a diagnosis. And sometimes it's even longer to proper treatment and proper intervention. So really, I assume that struggling that long can probably contribute to weakening of the pelvic floor or dysenergy of the pelvic floor over the long term too.
Well, yeah, and the more you train those nerve pathways, it becomes a habit. So someone you'll equate to having a limp or something walking. You sometimes don't even realize you're doing it, but if you limp for a long time, it becomes your sort of new normal. So retraining it, you're also retraining the pathway of sort of the messaging from your brain down to those muscles, to get that function working, but properly as it should.
Yeah, and so I think this is a common question, especially with my male patients, but can both men and women have pelvic floor issues?
Yeah, so both men and women have pelvic floor muscles, so they can both experience dysfunction, but the men's pelvic health has fallen a little bit behind in research, and pelvic health problems are basically receive more attention in the medical community from women, and I would probably associate that with just the whole childbirth piece. And the other thing that probably is happening is women tend to talk a little bit more than men, whether it's to their health care professional or just to women in general. I think women share a little bit more personal information than men do. And women, especially after kids and these mommy groups, people kind of chat, and I don't think men have, that's a generalization, but a lot of them, there's not that community feel where they're feeling very open to share those challenges that they're having. So a lot of them do sort of suffer in silence, unfortunately.
For sure.
Or don't realize there's treatment for it, right? So, yeah.
Or that belief that, this is normal, or I've seen a lot of like post-colorectal cancer patients that may struggle with the stool leakage and that sort of thing, which I'm sure pelvic floor might play a role in. But it's that conversation piece around it, and that whole comfort and talking about bowel health in a way that is comfortable and is normal and is something that's asked about is something that I hugely advocate for, because it's that exactly what you said, that suffer in silence mentality. A lot of times there's healthcare practitioners that can help you with these symptoms, with these things that are going on that are impacting your quality of life. So if this is something you're struggling with, talk with your physiotherapist, talk with your doctor, talk with your dietitian, and they can put you in the right direction to get the support that you need and the treatment that you potentially could get benefit from.
Yeah, and I would just say you're not alone. Even in men showing incontinence, the rates are 1 in 9, which is a lot higher than I would have even thought before I started the training. I thought, that's quite high, actually. Something you wouldn't expect. 1 in 3 women, right? So it's not as common, but it's common. I think people just don't talk. The conversation isn't happening, unfortunately.
For sure. So if people suspect that they may have issues with their pelvic floor, or maybe seeing a dietitian or a physiotherapist or a doctor, how would they go about getting their pelvic floor assessed, or where should they start?
Yeah, so depending on the area you're in, most pelvic floor therapists everyone's trained as a pelvic floor therapist. So depending on the location, there's different clinics that offer it. So at our clinic, at Evidence Sport and Spine, I myself am here, and we have a clinic in the north through Momentum, and there's a pelvic health therapist there as well. Oops, I'm losing a headphone. And so what an assessment sort of involves, because some people ask, well, what do you guys do? So we go through an extensive history. So we're looking at gynecological history, bowel and bladder habits, obstetric, and then just general sort of medical history. And then I'll do a full orthopedic assessment or musculoskeletal. So what people would maybe generalize as a normal physio assessment. So I'd be looking at breathing, posture, more focus on the back abdomen, pelvis, and hips. So range of motion, strength in those areas, looking at both connective tissue, so that superficial layer around the muscles, and then the muscles themselves. So we're looking for anything that could be going on in those areas. And then we do an internal exam. So for men, that would involve a rectal exam, and for women, that would include both a vaginal and rectal exam. And so what we're looking for is any sort of areas of pain. We're looking for how those muscles feel in terms of strength, again, any tightness, and how they're coordinating. So getting them to do a Kegel or relaxation and seeing what happens, see how it feels side to side, front to back, how they cue their pelvic floor. And then following that, depending on what we see, that's when we start going into treatment. So everyone's given an individual treatment plan, which generally involves some education. So depending on what they need. So it might be their bowel and bladder habits, toileting posture. We might talk about their fluid intake, fiber intake, and then giving them some just background on the pelvic floor. So what's sort of happening, what symptoms they're having and how their muscles may be contributing to it. And then going through exercises. So it might not be strengthening. If they're tight, we'd be focusing more on that relaxation piece, and just getting people in tune with their pelvic floor. And so, it would just be a graduated exercise program for these patients, just depends on what we see that they have.
For sure. So really individualized, really based on what you're seeing rather than that whole just do Kegels. I feel like if you grew up in the 90s, early 2000s, it was Kegels crazy. And you had mentioned to me that it's just Kegels is a myth.
Yeah. So I would say, and it's still being said, I'll still have patients say, oh, well, my doctor said, or it could be a friend, or, oh yeah, just do your Kegels, or I just do them at a stoplight. And that it requires a bit more. Some people can do that and be continent and have no pelvic floor issues. But then there's, a lot of people have these issues and they think, oh, I'll just do Kegels. And yeah, they may be doing more harm than good, depending on, what you have. And having that exercise program, and we'll use a lot of imagery. So some people may only activate the front of their pelvic floor and not the back. So we have to cue them. And the only way to really feel how that's working is to do that internal exam. So, there's some stuff we can do if people are very uncomfortable with having an internal. We can do work externally. You're just missing sort of a piece of the puzzle. So it generally will take a lot longer to get things better. And if you don't have that piece, which is such an important piece of the puzzle, is feeling how those muscles are working.
And that's why I think it's so valuable to have somebody like you who has the specialized training in pelvic health physiotherapy and has the experience and has, the exposure to it, to give people that really individualized help. So I think that's great. Mm-hmm. So guys, do you have anything else to add actually, Renae, to the end of this interview?
I don't think so. I would just say, if you're having issues, just know that you're not alone. It's very common, and that it's common but not normal. So some people will say, it's normal to have leakage after childbirth, or it's normal to have that with age, or I'm always constipated. So that's kind of normal. None of that is normal. It's common, but it's not normal. And I just think people shouldn't have to live with those issues. So I would seek treatment.
Yeah, that's
or at least an assessment to get an idea of what's going on. And generally, it's not treatment 3 times a week for 6 weeks. It takes some time. And so a lot of treatments are spaced out with you having to work on that stuff on your own. But you need those first sessions to get, to make sure you're doing things properly and releasing the appropriate muscles.
That's really great. And I think, it's again, just showing people that it's one piece of the puzzle in regards to managing something like a functional gut disorder, IBS, whether it's IBS-D or IBS-C. Pelvic floor physiotherapy is just one piece of that puzzle, one piece of that healthcare picture that you can get guidance and assistance with through your healthcare providers. So Renae is from Evidence Sport and Spine. So you can check them out on Facebook at Evidence Sport and Spine, or on Instagram at Evidence Sport and Spine. And you can also hop over to their website at evidencesportandspinal.com. And of course, if you want to hop over to Ignite Nutrition Inc., you can always do that. I'm Andrea Hardy, registered dietitian, and I specialize in gut health. So Renae touched a little bit on those nutrition pieces, and they definitely play a role. However, I oftentimes find that we need a multifaceted approach to manage IBS and get your quality of life back. So thank you so much, Renae, for coming today. I'm so glad we were able to touch base, and I can't wait to start to see this movement of, all these different multidisciplinary care providers providing really great interventions, kind of all together, all coordinated. So I'm excited to see patients alongside you and really help to get people feeling the best they possibly can.
Yes, ditto.
Awesome.
Yeah, thanks for having me.
Yeah, if you have any questions, guys, shoot me an email, info@ignitenutrition.ca, and I can always forward that to Renae as well. We'll see you guys all later. Bye.
Bye.